Thank you for coming. Welcome to Baltimore. Welcome to EMS today. This is exciting. This is my first time presenting at Baltimore, and I'll mention that in a few minutes. So thank you for choosing to come to this session. I was looking at all of the boards, all the lectures out there, and I was looking at the presentations I'm giving over the next 2 days, and I was looking at everything else that was going on, and I was like, there's some really good stuff here. I wonder if I'm going to have an audience. So thank you for coming. My name is Ryan Gerecht. I am from Cincinnati, Ohio. I'm an emergency medicine physician there, as well as an EMS physician, fellow in EMS medicine. I work with a variety of departments, big and small. Also fly as an active flight physician with our 3 aircraft HEM service. So we're going to be talking today about the art of trauma resuscitation, or more specifically, the art of pre-hospital trauma resuscitation. When I was thinking about topics to present at EMS today, when I was thinking of ideas, I was trying to think, what could we talk about for an hour and a half, which is a long time, that would be useful and applicable and relevant to the paramedic, the EMT, the firefighter, the flight nurse, the whoever who is first day on the job, as well as the same applicability and same learning potential as somebody who's been on the job for 30 years. And that's the goal. The second goal is to actually give real life tips that you can take out to the truck tomorrow. I love going to conferences and I love going to lectures and learning a variety of things, but if I don't have tangible skills to actually take to my patients, my truck, my personnel, to my partner tomorrow, it always leaves me wanting more. So I think the next hour and a half will achieve both of those objectives. So I've been involved in EMS for almost 15 years. I started out as a volunteer EMT doing rural EMS. I've done search and rescue. I've worked in bigger urban systems, now as a medical director, flight physician, and I 100% know from experience and believe at my very core that what we do, what you do, what I do in the pre-hospital setting actually makes a difference, and sometimes what we don't do makes a difference. And so this is a lecture, this is a talk, a topic that gets at both of those, which is the very nidus and the reason why I have a passion for EMS education. So let me start with this quote. It is not my own. This is Dr. Ed Rock, Chief Medical Officer for AMR. He said this at a conference a couple of years ago, and it stuck with me. He said this in an open forum to a room even bigger than this, and I was sitting somewhere near the back, and I thought, that is the most profound thing I have heard in years of going to EMS conferences. EMS is a practice of medicine. We're in the business of delivering health care to a very unique population in a very unique environment in a very unique way. And if you think about that EMS is a practice of medicine, the next 100 slides make a lot more sense, and we put a framework on EMS trauma resuscitation as a practice of medicine. So a bunch of thank yous. When I was growing up in EMS in Southwest Missouri, this was always a conference that I wanted to attend, always aspired to attend, and was never able to. So the fact that I get to be here today and talk with you is actually truly a very personal and humble honor. So thank you for showing up. Thank you for allowing me to speak. I do have a disclosure. Part of my fellowship supported by Physio Control and an AMSP has nothing to do with this lecture today. So here are the objectives. We're going to define the lethal triad, and I am embarrassed to admit that I took care of trauma patients for probably 10 years and had no real concept of what it was that I was actually trying to fight against. Car goes crash, gun goes off, somebody gets stabbed, and when I was starting out in EMS and when I started out early in medicine, I thought that the enemy was the stab wound to the liver, or the broken femur that I could see, or the head injury that I assumed that they had. And it wasn't till in the last 5 years I've really become to understand that really the enemy in trauma is something called the lethal triad. And so we'll go over that in great detail. We're going to recognize, I hopefully send you out recognizing what you can do to actually make a difference in the trauma resuscitation of the critically injured patient. Those will be the bucket items. Those will be the take home tomorrow, use them on the truck pearls. We're going to understand the role of EMS in damage control resuscitation. This is a concept that you might have heard, you might have kind of seen this in various journals, magazines, trade journals, lectures, continuing ed, wherever. The idea of damage control resuscitation. This has classically been a hospital term. It's classically been it's certainly well used in the military and understood in the military. But there is more and more evidence, rightfully so, that this principle of damage control resuscitation, that the real owners of this resuscitation technique, the real wheelhouse for this is you. And so there are new terms popping up, remote damage control, ground zero damage control, and so we'll talk about that. And then we're going to look to the future in the last little bit of what trauma resuscitation, specifically the resuscitation aspect, may look like in your lifetime, hopefully in my lifetime, etc. So we're going to start with a case. It was a dark and stormy night, 3 in the morning, and you're dispatched, engine 35, medic 35, medic 24, ALS 35, it's our paramedic lieutenant. At around 2 in the morning for a gunshot wound. It's a failed home invasion, you get that on your CAD. 2 victims, 1 DOA per police, the scene is secure. Your one patient, it's a 46-year-old male. Primary survey, he's lethargic, he is awake, but he is certainly very confused. His airway is patent, at least for the time being. His breathing is certainly labored. He has absolutely no palpable radial pulse. He has a weak carotid, and he's got 2 holes, entrance, exit, who knows, but he's got 2 holes to the center abdomen. Been on a call like this recently? In recent history? For some systems, this is an everyday occurrence. Vitals as you see them. 66 over palp, heart rate 131, tachypnea to 31, and he's maintaining his sats at 95%. Certainly sick. He's got a side stream end tidal of 20 and a glucose and a non-diabetic of 410, which are both markers of really, really bad badness in him. End tidal less than 25. We tend to think it might be associated with poor perfusion, metabolic acidosis, lactic acidosis, etc. So this gentleman is very, very ill. And you're about 20 minutes. This is our level 1 trauma center in Cincinnati. I think they had to wheel all of the patients in the hallway, take the picture, and wheel them all back in. I've never in 5 years seen it like that. But apparently it does actually look like that. So you're 20 minutes from the level 1 trauma center. What can you do? What do you do for this patient? 2 holes, center mass, is about ready to code on you, as sick as trauma gets. What do we have to do? And that's a question that you think about your own system, think about the equipment in your bags, think about the resources available to you. Maybe this is go to the closest receiving facility, maybe this is call a helicopter, maybe this is just a whole lot of diesel fuel. Whatever the case may be, think about your system. I'll leave you with a quote. Next, when I hit this button, a quote is going to come up. The quote is what was told to me at the age of 18 years old, the first time I brought a gunshot wound into a level 1 trauma. It'll remain nameless. But it was a quote that was said to me at 18 years old as a very impressionable EMT when I asked a senior clinician, hey, what could I have done for this patient, for this patient who's very similarly injured? The most important thing you can do is bring the patient to me so I can save their life. And that was what I was told at 18 years ago, at the age of 18 as an EMT. And I went through a lot of my trauma care and my resuscitation in the following years as a very, with that saying in my mind and that belief that for that wound, center to the chest, to the box where there's no tourniquet, I don't have an operating room. I'm not even a doctor at that point. I was a volunteer EMT. That there was literally nothing I could do for that critically ill, injured patient, who I actually knew personally that first time, that I could do to save their life was to press on the gas. And so in 2015, we have to do much more. The bar has been raised, and that's exactly what we're going to talk about today. Anybody know what that helicopter is? It's pretty much just the coolest machine ever made. That's a Bell 47. That revolutionized trauma care, medical care in the Korean War. I love the fact that this picture, the patient, is outside the helicopter. There is no medical care being rendered. And I think that's where some of that philosophy of just bring them to me as soon as possible and I will save their life comes from. Things have changed. Things have certainly changed. What we know in 2015 is that through action, and very specifically through inaction, you, I, can make a very real difference for the patient that we're talking about. But first, you have to know your enemy. So know your enemy. The enemy is this. How many folks, just by a show of hands, how many folks have heard about the Lethal Triad, read about the Lethal Triad, taught about the Lethal Triad? Good, good. Maybe a third? So for you, hopefully the next little bit of the presentation will be a review. Maybe it'll add to some of the knowledge that you already have. If you haven't heard of the Lethal Triad, this is the enemy that we have to know in caring for the trauma patient. It was first recognized, the Lethal Triad was first recognized in Denver, Colorado in 1982 in essentially a landmark statement that went like this. Findings suggest that coagulopathy, hypothermia, and acidosis are complicating factors which demand as much attention by the surgeon as the initial resuscitation and operative control classically emphasized. The nidus for this statement and for this paper was that these trauma surgeons at a very well-respected, very famous trauma center were taking very sick trauma patients to the operating room and they were fixing every hole. They were fixing every broken bone. They were cutting out what was bleeding. They were classically doing exactly what they should do in the operating room. And yet what they were finding was that patients would still go on days and weeks later to die. And so they asked themselves, but if I fixed every hole, if I did everything I was supposed to do in the operating room, why are they still dying? And what they realized, it was the Lethal Triad that was at fault. So the Lethal Triad is this, and this is a big summary slide. It's a take-home slide. I think you have this in your handouts. The Lethal Triad, it was coined to be in that original paper in 1982, a bloody vicious cycle, and that is exactly what it is. It starts with bleeding, and it leads to three things that all beget themselves, and it goes round and round and round. So bleeding results in hypothermia, your temperature to drop, which results in coagulopathy. Coagulopathy is just a term, it's a broad term for the factors and the proteins, the systems in place in your body that make clot to stop bleeding don't work. That's all it is. So if you can't make clot, if you have a coagulopathy, you will bleed more. So bleeding causes hypothermia, coagulopathy, hypothermia causes more acidosis, acidosis causes more hypothermia, and the cycle goes round and round and round, ultimately resulting in more bleeding and ultimately death. And I have crystalloids as a contributing to that triangle, and we'll talk about that in a little bit. So that is, in one slide, the Lethal Triad. That is the enemy. The tenets of the triad. This is take-home point. It starts with bleeding, it ends with death. That's very simple. It starts with bleeding, and it ends with death. You cannot, I cannot, a trauma surgeon cannot predict when it will occur, nor how severe it will be. We have markers that tell us when it's present, but we can't predict the future. Once started, it will spiral out of control unless you and I take very drastic, meaningful, important actions and inactions to stop it. Once it gets started, it's a freight train that you can't get back. And so those are the tenets of the triad. So we're going to go through each point of the triad individually. So first up, hypothermia. So normal body temperature is classically defined as 37 degrees Celsius or 98.6. There's a range there, but we're all very familiar. 98.6, that's normal temperature. So we're on the same page. Hypothermia is defined as a core temperature less than 35 degrees Celsius or less than 95 degrees Fahrenheit. And it is critically important that we, forever moving forward, distinguish hypothermia from environmental sources and hypothermia in trauma. They are different. They are not the same, and they mean very different things for the patient. Found down in a snowbank is very different than I crashed my car with the same temperature. Very different. Here's why. In a study of over 400 cases of hypothermia due to exposure, so environmental exposure, a core temp less than 32 had a 21% mortality rate. Okay, 1 in 5. 1 in 5 die from environmental hypothermia if their core temp's less than 32. In a study of 71 trauma patients, a core temp less than 32 is associated with 100% mortality. And that is completely independent of the presence of shock, how badly they were injured, and the volume of fluid or resuscitation that they received. Hypothermia in trauma is an independent risk factor predictor of death. Studies over and over and over again have demonstrated that there is a significantly higher mortality among trauma victims with hypothermia. This question has been answered. This is truth. Trauma patients with hypothermia go on to need more fluids, which is more crystalloids, which is a bad thing, which we'll talk about in a little bit. Need more blood transfusions, longer hospital stays, more complications, etc. It is so important to separate out environmental hypothermia and hypothermia in trauma that we've actually revised a classification scheme to separate it out. We've actually created our own kind of scale that's well recognized and published in the literature that separates out trauma temperatures from environmental temperatures. So in traditional classification of hypothermia, mild is 32 to 35. In trauma, we say it's 34 to 36. In moderate, it's 28 to 32. For traditional, we say that's actually 32 to 34. Severe hypothermia in environmental exposures, traditional classification is 20 to 28 Celsius. In trauma, we say it's less than 32. We have significantly changed, as we should, our references for what it actually means to be hypothermic in trauma. So now the question you should ask is, well, how often does this actually happen, right? Okay, so impressive statistics. Doc, how much does this actually happen? This is a 1995 study of 302 HEMS patients. Nearly 50% had a temp less than 36 degrees on arrival to the ED. It was not, underline not, associated with the time of year. This is not just a winter thing, and you'll hear me, they'll talk about that over and over and over again. The highest risk patients were those over 65 and those that had been entrapped, not surprisingly. And only 4%, let me say that again, 4% had shivering. So when you look at your trauma patient and they are not shivering, the answer is they're not hypothermic. You don't know that unless you're actually taking that core temperature. Shivering in trauma is actually quite rare. Now, that was from 1995. How are we doing many years later? This is from 2012. This is the Hypotrom study. You know something is important in medicine if it gets its own name on the trial, right? Hypotrom study. So this was done in France. It was a multi-center observational study. This was all trauma victims 18 years or older. They were transported by and cared for by their mobile intensive care unit, which, to the best of my understanding, is a physician-paramedic model. Primary endpoint was hypothermia on arrival at the ED. They looked at 460 patients, and they found that 14% of their patients arrived hypothermic. So not as bad as 50%. But this is in year 2012 with a mobile intensive care unit on a scene. Still, 14% of patients are arriving to the emergency department hypothermic. They went further and they helped us. They did you and I a great service. They looked at actually what were the risk factors. Severity of injury. More severe injury, the more hypothermic they would be. Head injury, intubation. If you're actually doing an RSI, putting somebody down and doing that intubation in the field, that's a risk factor for them getting hypothermic. Fluid temperature, 70 degrees Fahrenheit. How many folks right now, your normal saline is sitting in your truck in a station somewhere at room temperature? Most are, right? Mine are, in some of my agencies. That 70 degrees is actually hypothermic compared to the patient, and we'll talk more about that. Transport unit temperature is a key risk factor for hypothermia. Patients completely unclothed, and scene temperature is not an independent risk factor. Again, another study, more patients. The time of the season, the temperature outside has nothing to do as that independent risk factor for hypothermia. Now, snow and cold below freezing, certainly it can contribute, but the important thing to take away from that is just because it's July and 100 degrees outside does not mean your patient's not going to get hypothermic. That's the key point. So the causes, we all kind of know, we all kind of are aware of these. These are the ones that we think of. Temperature and moisture, is it raining? What's the wind speed? How long have they been in exposure? Is this somebody where the accident just happened, or is this a prolonged extrication? Is this somebody that went over the side of the road and we don't really know how long they've been there? All of these things, environmental exposures causing increased heat loss certainly play a role. But keep in mind, even room temperature inside a building is hypothermic relative to the patient. So just because somebody gets shot inside of a house that is a comfortable 70 degrees, that is a hypothermic environment compared to that body temperature. Additional causes, blood loss, you lose the insulating fluid that's making you warm. Fluids, crystalloids, normal saline, lactated ringers stored at room temperature inside the ambulance, that is actually hypothermic. If you figure that that temperature is 70 degrees, you want your patient more at 98.6 or more, that is hypothermic. Blood products. I'm guilty of this. I fly on a helicopter with blood products and we arrive at a scene and I take out of a chilled ice box, 34 degrees, 36 degrees blood products and put them in the veins. So you have to have solutions to fix that. And then burns, classically, we lose a lot of body heat, increased heat loss through burns. Here's the key thing here. So hypothermia causes, and this is probably most specific to the trauma patient. What we know is not only do we have environmental issues to overcome, we've got equipment logistics that will cause hypothermia. The patient themselves, when they are severely injured, they just simply will make less heat. Their metabolism is different. The central nervous system control over their heat mechanisms and their thermal regulation is very different than they were 15, 20 minutes prior. So injury and hemorrhagic shock cause it. Traumatic brain injury and spinal cord injuries will contribute to it. Other medical conditions, alcohol intoxication, patients at the extremes of age, little kids, older adults, sedation and paralytics. You take away, when you do etomidate, sucks, and rock, you take away that patient's intrinsic ability to warm themselves or their attempt to warm themselves. And so that's a cause or a risk. And then again, trauma patients rarely shiver. One study that I looked at, I took the study out just because of slides and time, showed that 1 in 80 trauma patients will actually shiver. 1 in 80 hypothermic trauma patients will actually shiver. So just keep that in mind. So what happens when you are hypothermic? This is key. This is in your handout. There are a variety of different things, but I have bolded for you kind of the key things to take away. Decreased cardiac output, decreased cardiovascular response to catecholamines, whether the ones you give them or the ones that are intrinsically in their body, epinephrine. Arrhythmias, ventricular fibrillation being most common, AFib being another one. Peripheral vasoconstriction, you have impaired release of the oxygen from the hemoglobin. Bleeding, and this is where it contributes to the lethal triad. So for each degree of temperature decrease, you have a 10% decrease in your ability to make clot. It contributes directly to the coagulopathy, directly to the bleeding that is killing your patient. Reduced platelet function to make clot, yet again, another aspect of the coagulopathy that is contributing to that triad. There are downstream effects that hypothermia contributes to, such as infection in the hospital. So the simple truths are this. Unintended hypothermia in trauma victims remains a common problem. There's multiple reasons why hypothermia occurs early in a resuscitation. It's a key factor in the lethal triad, and at the end of the day, it's happening before your eyes, regardless of the time of year. Hypothermia in trauma increases the likelihood of death, period. It just does. So the next point, acidosis. So just so that we have some common terms and we're all on the same page, pH level is a measure of the blood's acidity on a scale of 0 to 14. Water, just normal water, is a pH of 7, right there in the middle. Our body, normally, if I went around and took a sample from all of you, would be somewhere around 7.35 to 7.45. We call an acidosis when that pH, when that measurement goes below 7.35. And there are a couple of different types. There's kind of broad sweeping strokes to the way to look at acidosis. One is metabolic. So something in your body is either making more acid, not getting rid of acid, you've ingested acid or taken in acid, or from a variety of different forms, or the second category is respiratory, and this has to do with your ventilation, your end-tidal CO2, your CO2, etc. So kind of two broad categories, and that's important to everybody on the same page moving forward. So the major cause of acidosis in trauma is summed up in a single slide, and there's a lot of words on that slide, but this is the process that causes acidosis in trauma. In trauma, you have impaired oxygen delivery to the tissues, and it's all about oxygen delivery meeting oxygen demand. When delivery doesn't meet demand, you have shock, right? Shock is not a blood pressure, has nothing to do with their blood pressure. Shock is a physiologic state where your body needs more oxygen than what it's delivering. So in trauma, you have impaired delivery of oxygen to the tissues because the substance that is needing to do that, blood, has been lost. You have peripheral vasoconstriction, as we already kind of talked about, perhaps from hypothermia, perhaps from your body trying to maintain its vasoconstriction and blood pressure. And you have decreased cardiac output from a variety of different things. It could be from a substance that they ingested before they crashed the car. It could be because they have a baseline heart failure. It could be because they have a congenital heart disease. It could be because they're hypothermic. It could be because they're on a beta blocker. A variety of different things can cause that decreased cardiac output. So tissue O2 demand exceeds that of delivery, you have shock. And when that happens, your body still needs to make energy, right? Life must continue on to the best of its ability. And so when you don't have oxygen, every cell in your body will flip, well, not every cell, but most cells will flip over into your body, and they will use anaerobic metabolism to make energy. And the byproduct of that, when they don't have oxygen to make energy, is lactic acid, and that contributes to a metabolic acidosis. So that is kind of the big key thing in trauma. Tissue O2 demand exceeds that of delivery. Your cells, as a result, need some way to make energy, and a byproduct of that is lactic acid. That process is lactic acid. That makes you have a metabolic acidosis. We can screen for that. Folks are starting to do this. We certainly do this in the hospital. We're actually measuring lactate. We're measuring it in sepsis, we're measuring it in trauma patients, and we know that a level over 4 it suggests severe illness or injury in that patient. Is any system here using point-of-care lactate? Excellent. So this is coming. It looks like a glucose monitor. It's a finger stick item. They're commonly available for athletic training, etc. There's a little bit of issues with FDA approval and kind of vetting some of that process, but they're there, they're coming. There are systems in Ohio, where I am from, that are doing this. This is coming. This lactate monitoring, measuring this lactic acid in the bloodstream as a marker of critical illness, is coming. Now, when you have lactic acidosis, and you have this in the face of normal vital signs, when you have shock in the face of normal vital signs, we call that cryptic shock. And that is a term to take home, it's a term to read about, understand that this process that I'm talking about of oxygen demand and delivery not matching up can occur absolutely in the face of a normal blood pressure, and we call that cryptic shock. That's the reason why lactate is being measured. We'll talk a little bit more about that. So other causes of acidosis, the fluid that we give, this is a bag of normal saline, pH is 5.6. I told you, remember that pH normal 7.35 to 7.45 is a range, 7.4 kind of ballpark it. The normal saline we give is acidotic. It also has a lot of chloride in it, so that makes another metabolic acidosis called hyperchloremic metabolic acidosis. Now you might say, well, what about lactated ringers? That's what we use. Its pH also 6.2, so the very fluids that we're giving are acidotic. Other causes are respiratory causes, causing hypercapnia, respiratory acidosis, narcotic, alcohol use, traumatic brain injuries, flail chest, other medical conditions. These all contribute and add on to the existing metabolic acidosis or lactic acidosis in a trauma patient. So what happens with acidosis and trauma? You have, again, decreased cardiac output. Your response to epinephrine, the catecholamines, don't work as well. You start to hyperventilate. We see that all the time with our patients. Start to have decreasing mental status, coma, and then again, for the lethal triad, a decreased function in how well your body makes clot, a significant decrease in how the factors work and the platelets work that make clot to stop bleeding. So the simple truths are this. Your patient's likely already acidotic. Sometimes the treatment that you're supposed to do by protocol, what you've been told and instructed and taught to do for years, can actually make the acidosis work. And when the pH drops from just 7.4 down to 7, there are parts of the clotting cascade whose function decrease 55 to 70%. The system, the very system in place that is trying to stop your bleeding, is functioning at 50 to 70% capacity. And at the end of the day, hypothermia plus acidosis is worse than either by itself. It is synergistic together. You could be a hypothermic patient and an acidotic patient, and that together is even worse than just if they were hypothermic and acidotic. So coagulopathy, I'm sorry that doesn't project very well. Lighting is different in here, my apologies. Coagulopathy. So I told you before at the beginning of the talk, coagulopathy is a condition where the proteins, the factors, the system in your body that is used to make clot functionally doesn't work. For whatever reason. There can be a variety of different causes, but it doesn't work, and as a result, you bleed more. That's it, in a nutshell. It's present in nearly 1 in 4 severely injured patients arriving in the ED. 25% of severely injured patients that you're taking care of are already coagulopathic. And its presence is a 4 to 5-fold increase in mortality. 4 to 5-fold increase in mortality, beyond whatever other injuries and mortality rate they already have. 4 to 5-fold increase. When I read this, I had a feeling that this statistic would be there. When I actually found it in literature preparing for this talk, it blew me away. Trauma-induced coagulopathy is evident within 15 minutes of injury in nearly 30% of severely injured patients. And so I put that up there to very much make sure that everybody in the room, we all understand that this is our problem. This is an EMS problem. It is happening to your patients that you're caring for, that you are delivering their care to. It happens within 15 minutes of injury. Even in my big urban system, sometimes we don't get transports unit there, right around 15 minutes. So it happens very, very quickly. Causes of coagulopathy. So we already talked about hypothermia and acidosis. Tissue injury itself starts this process of inflammation, cytokines release, similar to sepsis, where your body just has a systemic inflammatory response to the injury that it has. That can make you have coagulopathy. Hemorrhage, you just lose the factors that you need. They are now not in your body, they are now on the sidewalk, right? Significant risk factors. We already talked about acidosis. We already talked about temperature. Injury severity score, ISS, is just how badly they're injured. So the more injured patient who's hypothermic, acidotic, who's hypotensive, we've all taken care of these patients, the probability that they have a coagulopathy and are going to bleed more, that their clotting factors are not working, is 98%. Hypoxia contributes. Dilution of the remaining clotting factors. So you've bled a lot of clotting factors on the sidewalk. What is left in your body now gets diluted by a bunch of normal saline. A couple of liters. When I went to medic school, it was 2 liters wide open, 8 large bore IVs in the ACs, and 2 liters boom and reassess, right? We now know that fluid approach, that resuscitation strategy, dilutes the clotting factors that are still left in the body. And then your body can also have abnormal activation of clotting cascade, where it gets really sick and it starts to make clot, and then it breaks down clot and it uses up what it's not supposed to be doing, and there's some chaos there. TBI worsens coagulopathy. 80% of patients with a GCS less than 6. Pre-existing medical conditions, medications, Coumadin, novel anticoagulants, they give your patient already from the get-go a coagulopathy. They don't make clot like they're supposed to. So simple truths are this. Trauma patients are frequently coagulopathic. The more severe the injury, the worse the coagulopathy. Coagulopathy results in worsening hemorrhage. Once the coagulopathy of trauma is present, it is very difficult to reverse. And I think that is absolutely key to recognize. Evidence of that is this. So one of the ways we treat coagulopathy, and I didn't say this already, I'll say it now. One of the ways we treat coagulopathy, whether it be in the emergency department, in the operating room, in the ICU, is that we give those clotting factors back to the patient through plasma, through blood transfusions, etc. We give them those products, or we give them those factors that they need to make clot. Okay, and we'll talk more about this towards the end of the presentation. The coagulopathy that occurs with trauma is so complex, it is so important to prevent. Studies show us that the coagulopathy that happens from hypothermia, just from hypothermia, is refractory a lot of times to the blood product administration, that only by warming that patient back up do we actually fix the problem. And so that leads us to this, which at the end of the day, when it comes to coagulopathy, an ounce of prevention is worth a pound of cure. And I think that that's absolutely critical for us to understand that, yes, we don't have the lab machines or at least routinely have those in the pre-hospital setting to check what somebody's INR is or something like that, some measure of coagulopathy. But instead, we should just assume that this is happening. We should assume, based on what we know, that the patient's likely hypothermic, they're likely massively injured, they're likely acidotic, that this is there, and we have to do everything in our power in those first critical minutes. Remember, in the first 15 minutes, 1/3 of severely injured patients already have this. So an ounce of prevention is worth a pound of cure. So how do we manage this? How do we manage this? So I'll show you this slide again, the take-home slide. This is the target. And everything we do moving out of this room today, back on the trucks tomorrow or Saturday or Sunday, everything we do moving forward has to target some aspect of this triad. This is the goal. This is the aim. So number one, do not underestimate the environment. I've already emphasized that several times. I put this picture up there. I'm not sure what agency this is. I found this online. I put that picture up there because it's absolutely striking to me, the prioritization of that tarp. That's an entire engine company, plus, that is making that happen. There is an entire company dedicated to keeping everybody dry, essentially. Now, you might think, oh, there's a lot of tools in there, there's fluids, whatnot, it's a safety issue. But actually prioritizing, that scene is prioritized to actually do the very best that they can in the environment that they're given. Patients can and will become hypothermic in conditions you consider warm. I can't say that enough. It's ironic to me that we heat up our ambulances, we do lots of things, but the backboard rides on the outside of the truck, right? How many people right now, if you think about your apparatus, you ride on all the time, the backboard's on the outside of the truck, right? Mine are, right? We take this critically injured patient, and we've done all of these things to keep them warm, and we're prioritizing them, but the one thing that we put them on that they're going to lie on for the 30-minute transport and the 15 minutes in the ED before they get log rolled off the backboard is sitting outside at ambient temperature, 32, 40, below freezing, whatever the case may be. So think about that. This is not a discussion on backboards. That's a different lecture topic, but just recognize that if the situation is there where you are actually placing somebody on a backboard, those situations are probably going to become fewer and fewer and fewer as the next 5-10 years progress, which is a good thing. Just remember that we're putting them on not only a hard, uncomfortable surface, but a potentially frozen surface. So create an insulated surface. Just recognize that that's there. Promptly remove wet clothing, right? So we know this, we've been taught this, we need to do this. Not only does it make them more hypothermic, but the real physiologic reason is, I told you that trauma patients don't shiver, but those trauma patients that do shiver, they are absolutely wasting energy and oxygen. And that's the key thing. At the very end of the day, this is all about oxygen demand and oxygen delivery. And they're wasting valuable energy. They're wasting valuable supplies trying to keep themselves warm. So shivering is absolutely not what we want our patients to be doing with regards to wet clothing in their environment. Strip them and flip them, right? We've all been taught that, right? I bet some of you have even taught that, right? I mean, I have. I'm right there with you. Strip them and flip them. That's what we have been. That's what we've taught. That's what we've learned. That's what students say. And I would say, great, but do it with surgical precision. Surgical precision. Do a complete exam. You have to see every aspect. Don't miss the hidden injuries. We'll talk about that. but then cover back up the part of the body that you're not examining. Keep it covered, right? In this picture, the patient's getting intubated, they're fully exposed, right? There's 2 risk factors for hypothermia, just that we can see right there. I have no idea what the patient's temperature was, but just recognize that those are a couple of risk factors. So yeah, absolutely, we have to get them undressed, we have to know what their injuries are, but then we absolutely should cover them back up once we have deemed that area clear of injury that we need to intervene on. Warming blankets. So how many folks right now at the end of their cot in 30-degree weather have a nice cotton blanket sitting right there at the foot of the cot, right? Right, if you're lucky enough to have the hospital give you some, right? I mean, so this is another area where, depending on finances and operations and all of that, I'm very sensitive to that. There are other products on the market, none of which I take any money from. I'm just sharing with you what I have found in my own kind of research to improve my own systems that I work in. There are a variety of different products, from just simple heat packs to space blankets, emergency blankets, to the ready to heat first responder. I mean, the military created in 2005 a hypothermia prevention and treatment packet, a bundle. I mean, things that get bundled in medicine are big, important things. Sepsis bundles, STEMI bundles, stroke bundles, right? I mean, those are things that we care about in medicine. The military recognized that we need to have a plan, a kit in place for our injured soldiers. And with that, they've shown great results. They've shown hypothermia rates drop into the single-digit % range. So this can be done. This can be done. 80 degrees Fahrenheit. So how often do we actually pay attention to what the temperature is in the back of the ambulance? Some say 80 degrees is kind of ideal. Some say 85, depending on the literature you read. My marker at 3 in the morning when I'm actually in the truck working is I should be sweating, right? I should be sweating before I get to the scene. It's warm enough in the rig, right? I mean, it should be very, very warm, pre-warmed for the patient, not comfortable for us en route to the scene and then flip up the heater once the patient's in the ambulance, right? It should be already warm, ready to go. Warm fluids. So I already said that the fluids at room temperature are hypothermic. Now, and I'm a big proponent of therapeutic hypothermia. I just think it's interesting in the last 5 years that we have focused on how to chill our fluids, make them colder for a possible benefit, when we actually know that heating our fluids does make a difference. Think about that. In the last 5 years, we've spent a lot of time as an EMS profession in a community thinking, how can I enact therapeutic hypothermia? We're doing it too. Our system looks at it as well. But how many folks are looking at it going, how am I keeping the fluids that I have to give actually warm? Pay attention to this picture where they're actually keeping warm the 5 feet of IV tubing, right? That's a critically important detail. It can be warm up here, but you got to figure out a way to also keep it warm as it runs through that IV tubing. So just something to think about. So remember, your patient's temperature is dropping right before your eyes, much faster than you expect. Maximized oxygenation is needed. So there is a whole nother kind of topic for this conference, and worthy of an hour and a half discussion on when do trauma patients actually need oxygen, right? I mean, that's a huge topic of debate and research. My boss does a lot of that research, and so I won't belabor that too much, other than just to say that hypoxia does contribute to the triad. We should maximize oxygenation when they need it. Not everybody needs 100% non-rebreather when their starting sats are 100%, but we should maximize their oxygen when they need it. And treat causes of hypoventilation. That may be Narcan, it may be an albuterol, whatever the case may be with regards to their hypoventilation causing their respiratory acidosis. Now, I talked about lactic acid monitors and that I thought this was coming, that it's there in certain parts of the country. It's another tool. It costs money. There are operational costs with it, and certainly that is an issue for some systems. Another work of ongoing research that you should be paying attention to is the work out of Orange County, Florida, with regards to end-tidal CO2 and how it correlates. So a tool that we all have, or hopefully most of us have, on our trucks in operation today, end-tidal CO2, and how does that correlate with lactic acid elevation. And they are doing great, fantastic work. We don't have enough time to talk about that today, but that is another tool that we should be paying attention to, and an area of active research that we should all be looking at for the future. Understand, and this is a big one, I work in a level 1 trauma center, I cannot tell you how many times we find out hours later that folks were on some of these meds. So do everything possible. Grab the purse, grab a phone number for family members, do anything that you grab, all the meds, do whatever you can to make sure that the continuum of care inside the hospital understands what medications the patient is on. The patient's on Plavix and Xarelto and Pradaxa, etc. When I started in EMS, it was Coumadin and aspirin, right? And now there's meds that I can't even keep, I can't spell the names, right? So I mean, it's changing every day, and we need to know as a continuum of care what medicines are on with regards to their intrinsic coagulopathy. All right, control hemorrhage. So I said it started with hemorrhage and that it ends with death. So it would make sense that one of the things that we have to do is control hemorrhage. It is the second leading cause of trauma mortality. Traumatic brain injury is the #1 cause of trauma mortality, but bleeding is #2. And it's the leading cause of preventable death. 56% of those deaths occur in your house, in our wheelhouse. This is our job. There is nobody who is better at this than us, controlling that preventable hemorrhage on the scene. And the key thing here is that we have to, and I've seen this several times in my career, we have to stop the hemorrhage, not slow it. And we'll talk a little bit about that. So there's a variety of different devices. I'm sure the exhibit hall will be full of those. It's interesting, when you look at hemorrhage control and you look at the speed with which EMS medicine has, and EMS, the practice of medicine, has skyrocketed into the future. I mean, we're talking about ECMO CPR, I mean, even 12-lead EKG 10 years ago, and Untitled CO2, and you talk about all the advances that we're making. Why has hemorrhage control, why has the fight for tourniquets been such a problem, right? I mean, that's something that systems face on a very real daily basis. It's interesting, and this is just one slide, the history of hemorrhage control and kind of the history behind what it means to stop bleeding. Up until the late 1800s, I mean, really not that in the distant past, bloodletting was felt to be an effective treatment to stop hemorrhage. Right? I mean, I guess if you bleed everybody out, they will eventually stop bleeding. All bleeding does eventually stop. But I mean, that was a real practice of medicine. And Dr. Osler, the father of modern medicine, advocated for that in the late 1800s, early 1900s. And then we all know through the world wars and whatnot, tourniquets being referred to the devil themselves and instruments of the devil, etc. That's a picture of our first president. That's a picture of George Washington on his deathbed. He was ill with an infection, and he had himself bloodlet 3.7 liters over the course of about 10 hours to try and treat that infection. He ultimately died, right? So we have an interesting history with regards to hemorrhage control. But what we know from recent military conflicts, and I have not had the honor and pleasure of serving in the military, I'm sure many of you have, but what we know from the last 10 years of conflict around the world is that the early use of tourniquet, without question, saves lives, period. There is the studies that support this go on and on and on to the point where I would have no time left to talk about anything else. There are dedicated sessions on hemorrhage control. But what I want to emphasize is early tourniquet use. Survival rate, a study in 2011 showed in military combat victims that if the tourniquet was placed before hemorrhagic shock, survival was 96%. If it was placed after hemorrhagic shock, survival rate of 4%. So early use of tourniquets. Development of a variety of hemostatic dressings for difficult to manage wounds. So we'll look at some of those in just a minute. A complete change, and for the EMS educators out there, for the officers in your agencies, a complete change in task prioritization, a change of how we educate the paramedic students and the EMT students of tomorrow. ABCs is very different. It has a very different place in our assessment in the practice of EMS medicine than compared to March. Does anybody teach or use March in their care of the trauma patient? Comes out of the military. They started using it in the 1990s or so, early 2000s. March stands for massive hemorrhage, airway, respiration, circulation, and hypothermia. It's a complete way of changing the priority of how we manage the trauma patient. Yes, they need to be intubated, but I am going to put a tourniquet on their leg first, take that out of the equation, and then I will attend to their airway. Right? It's a completely different way. Patients have died over and over and over again, bleeding from wounds. I've seen this in my own clinical practice, bleeding from wounds while we try and get the airway. So the military has it right. They are a step ahead of us in that march, massive hemorrhage, airway control, respiration, circulation, and hypothermia. Then there are a variety of novel devices as well. We'll show some pictures of that. At the end of the day, though, despite what new techniques come out, the new devices that come out, basic techniques are key and realistic training is required. I had the complete privilege and honor to train with one of the local police departments in a self-care law enforcement kind of TCCC class just before flying out here for the conference. And we did some lectures, we did some live scenarios with them, and I had the opportunity to play one of the live victims. And we did this scenario in a dark corner, down stairwells, down hallways, etc. And realistic training is absolutely key. It was absolutely fascinating to me to take not SWAT officers, not SWAT team operators, but regular road cops, put them through a 3-4 hour course on a lot of this and how quickly they make judgment calls to apply a tourniquet, when not to apply a tourniquet, when to apply a hemostatic dressing, when not to apply a hemostatic dressing, and how quickly they are able to do that in realistic training. So ask yourself, when was the last time you or your agency put on a tourniquet in the dark at 3 in the morning with one arm? Realistic training, not in a con ed room, kind of with a PowerPoint presentation, but actual realistic training. That is key and paramount above any additional tools of those basic skills and actually verifying that we understand how to hold direct pressure, how we actually put on the tourniquet and use it functionally. How is the cat tourniquet functionally different when you apply it to the arm versus the leg? Some of those subtle nuances. And at the end of the day, probably the biggest thing with tourniquets and the biggest thing with some of these devices is the hesitation factor. I felt it myself. I've been a part of it myself. I've done it myself, where you look at a wound and you go, that probably doesn't need a tourniquet. I'll just hold pressure, more ABD pads, more bandages, more ACE wraps, and before long they look like a snowman and they're still bleeding through their dressing, right? The hesitation that we all feel and we all recognize. But I hope with some of this evidence I'll show in the next couple of slides that we can get rid of that. Early control is critical. So some might say, and this has actually been, the stat up there at the top has actually been kind of given to me as debate. Civilian deaths due to isolated extremity hemorrhage is rare, less than 1%, but greater than 50% of these are preventable with tourniquets. So the argument is, well, if an isolated extremity hemorrhage death is so rare, do I really need these on the trucks? Do I really need to outfit these in the pre-hospital setting? And my rebuttal to that would be, well, there's over 50% of those are preventable, so that's number one. But number two, the tourniquet really has a different role than just isolated extremity hemorrhage. It has a very distinct role in the multi-system trauma patient. I already gave you that example of their leg is broken, they're bleeding out, they've got a tension pneumothorax, they need their airway managed. The multi-system trauma gets a tourniquet, and then I've got all sorts of other hands and focus that can be put on multiple other critical interventions. MCI, special operations, care under fire, certainly those all have a role. All right, so here is a statement that was put out in 2014 from NAMSP, American College of Surgeons, and it just basically goes on to endorse. This is the paper that you can take to a medical control board, to a hospital, etc., to kind of support your quest to get some of these devices in the pre-hospital setting. They recommend use of tourniquets in the pre-hospital setting for control of significant extremity hemorrhage. They suggest using commercially produced one. They don't suggest using narrow elastic bands, your belt, bungee type devices, etc. They recommend getting one that has been proven to work. They suggest that improvised tourniquets should only be applied if no commercial devices are otherwise available. And we suggest against releasing the tourniquet that has been properly applied in the pre-hospital setting. And I actually disagree with that a little bit. Our protocol locally is is actually gives the pre-hospital providers the opportunity to, once the chaos is settled, the care under fire is gone, the airway has been managed, to reassess the need for that tourniquet. But that's what this recommendation, so that'll be up to your own systems. They make recommendations for topical hemostatic agents in combination with direct pressure. They should be delivered in a gauze format that supports wound packing. Only products determined safe and standardized laboratory injury models should be used. TCCC recommends the combat gauze as first line, but also makes recommendations for celiacs and one other. And so these are out there, and they have support. They actually, in this paper that you can use and take forward, they have a nice little diagram of, you know, if you can control hemorrhage direct pressure, great, you're done. If it's amenable, but if you can and it's amenable to a tourniquet, put it on. If it needs to be packed, the wound needs to be packed because it's a junctional injury where you can't get a tourniquet, pack it. So this evidence is there, it's growing. But what about this injury? What do you do with that one? 2 bullet holes, 1 in, 1 out in the abdomen. Not going to put a tourniquet around it, or at least not a standard tourniquet. So this paper, when I was putting this together, made me overjoyed. It was fantastic to see this. Traumatic intra-abdominal hemorrhage control has current technology tipped the balance towards a role for pre-hospital intervention. A paper dedicated to focusing on the future of you and I controlling intra-abdominal hemorrhage in the pre-hospital setting. Revolutionary. What the answer previously was just diesel fuel and get them to the operating room. People are beginning to look at how that's going to change for the future. They looked at mechanical depression devices, endovascular control, energy-based hemostatic devices, so using ultrasound and whatnot to kind of help stop internal abdominal control hemorrhage. What they found is in most cases morbidity and mortality have been decreased. Now some of these products are not FDA approved, a lot of this is in animal models. I mean, there's more work to come, but in 2015 we are looking in that direction and it's exciting. So let me go back real quick. So here's a variety of different new devices or novel devices, many of whom that you may have already seen in the exhibit hall or been familiar with from last year. The JET, the SAMS junctional tourniquet also doubles as a pelvic binder, the abdominal aortic junctional tourniquet, and there is more evidence coming. There's more evidence that this works. There's more evidence that it controls hemorrhage, and that these are potentially a very operationally important part of what we do in the pre-hospital setting. There's more research being done on foam. I mean, I think this is an amazing idea and it's very cool. Oregon Health and Science and UT Southwestern looking at trauma foam, where you essentially would put 2 little chemicals essentially inside the abdomen. It blows up and basically just forms the perfect compression dressing of the entire abdomen. I mean, so there is more work. That research was presented at a national trauma meeting. There's working on FDA. So, I mean, folks are working on this in real time. Anybody from London Ambulance? I've seen them walking around in their coats. No, nobody here yet? No? Okay. So, London's Air Ambulance, just a few months ago, was the world's first, did the first pre-hospital Reboa. So this is a catheter that goes in the femoral vessels, gets traced up kind of into the mid-abdomen, lower chest, and a balloon gets blown up and essentially stops all blood flow to the abdomen and pelvis. Something that's only been previously done in the operating room, and they did it on the street with a guy with a bad pelvic injury. Very cool, amazing kind of forward-thinking interventions. Here they are in simulation practicing that. So these things have been done. I mean, this is real. This has been done. It was operationalized and completed. So that is some of the future that we're looking at. So one thing, though, when we talk about trauma foam and we talk about the Reboa and we talk about some of these things, it's exciting. It's very interesting. This is a review out of Canada, Canadian trauma centers. They looked at all the deaths over several years, looked at what the causes were. No surprise, traumatic brain injury was number 1, number 2 is hemorrhage. But then they went and they looked at the preventable hemorrhages. And of the hemorrhagic deaths, 16% were judged to be preventable because of significant delays in identifying the major source of hemorrhage. Hemorrhage from blunt pelvic injury was the major cause of exsanguination in 12 of the 14 preventable causes. So blunt pelvic trauma. Blunt injury is the major mechanism leading to trauma deaths. Massive bleeding from pelvic injury is the major cause of preventable hemorrhage deaths in our study. And so just a little bit of plug. We talk about things that are new, that are coming, the research that is being done, but a plug for something that we've already known but probably don't do as well as we could. We often forget what we cannot see. And so the question is, when do you bind a pelvis? When does your system bind a pelvis? When do you as a provider decide, I'm going to bind a pelvis? There was an article in December 2014 at GEMS that looked at that and talked a lot about that. I want you to read that article. I don't want to spoil the whole article. A couple of things that article talked about was the critical importance of EMS having a keen suspicion for pelvic injury. Rocking the pelvis is ridiculous. It's never been shown to actually be test-worthy. We've never been shown, even with the best orthopedic surgeons, to come in, rock a pelvis and go, yep, there's no injury there. In all the pelvis fractures I've ever seen, I've only felt one that truly rocked. Then there's evidence that rocking the pelvis, if it is unstable, dislodges clots inside the pelvis, worsens hemorrhage, etc. So rocking the pelvis is ridiculous. From our system, we have a very liberal use of pelvic binding. It's almost to the point of being, I guess, kind of mocked. We put pelvic binders on, and this is for our aircraft crews, we put pelvic binders on obvious pelvis instability. So if you show up, and I mean there's very clearly bones sticking out of the pelvis, etc., we bind that. We also put pelvis binders on those with shock and any low back pain or tenderness. This is irrespective of if it feels stable or not. This is just they're hypotensive, tachycardic, in hemorrhagic shock from blunt trauma, and they've got low back pain or tenderness in that general area, they get bound, no questions. Then we bind anybody, most of the time we bind anybody in blunt traumatic hemorrhagic shock with a GCS less than 13. Because what we realize is that with the mental status of less than 13, they can't tell me if their back hurts. They can't tell me if their pelvis hurts. So we bind them. So we take a very conservative approach to this because we often forget what we can't see. And then don't stop looking. The posterior, the axilla, the perineum. Look in the gluteal clefts, the buttocks, between the folds, down the street. These are all places where blood can hide. TXA. Who's using TXA? Good, good. 3, 4 hands. Good. So a lot of press on this. It's a hot topic. I don't have time to kind of go over all of the evidence. TXA is an antifibrinolytic agent, so it's been FDA approved for a variety of different indications for several decades, and then in 2010 with the CRASH 2 trial and the MATTERS trial, you might have heard of those, that it's kind of brought TXA into the trauma limelight. It's an antifibrinolytic, so what it does is it does not make clot. It stops your body from breaking down the clot it's already made. Does that make sense? Your body makes the clot. This medication keeps your body from breaking that down and thus stopping hemorrhage. It's made quite a bit of press. GEMS has covered it. GEMS is going to cover it again in April of this year. And so look at that. It's making press. It's an agent that it's affordable, and the numbers in terms of mortality are very, very good. So in our system in Southwest Ohio, who gets TXA? Age greater than 16, significant trauma, they're hemodynamically unstable, their time of injury must be less than 3 hours. So that's key to this medication. Injury time must be less than 3 hours. They get 1 gram of TXA over 10 minutes. That's our protocol. There's more of that online. I think I put the references to that in your handouts. What we know about TXA: decreases all-cause mortality, greatest benefit in severe shock. Early TXA less than 1 hour is the best mortality reduction. So what we know is that TXA in less than 3 hours from injury is good, but TXA within an hour is even better. And that makes it your medication. That makes it right there, then and there, makes it your medication. So EMS resuscitation, we do not bleed normal saline. So remember, it's acidotic, it's hypothermic, and it's dilutional. Beyond that, it goes on to cause renal dysfunction. Excessive hyperchloremic metabolic acidosis can cause kidney failure, bowel wall edema, brain edema. So there's a lot of different reasons why too much crystalloid is a bad thing. 1918, this is another reason why too much crystalloid in the trauma patient is a bad thing. Injection of a fluid that will increase blood pressure is dangerous in itself. If the pressure is raised before the surgeon is ready to check any bleeding, that might take place. blood that is sorely needed may be lost. Published in JAMA, 1918. And so this is getting at the idea of permissive hypotension. Everybody doing this? Have protocols for this? Permissive hypotension. So this is the idea that in trauma resuscitation we want to maintain vital organ perfusion, not necessarily a normal blood pressure. That we want to make sure that the important organs are being perfused, but not necessarily that they have a normal blood pressure. Adequate perfusion is the presence of a radial pulse or normal mental status. And you do this by giving small trials of fluid, 250 or so, with constant reassessment. If you get a radial pulse back, you have improvement in the mental status, then you stop. And the point or the thought is to attempt popping the clot. So raising the blood pressure disrupts a delicate clot, increases volume, stretches the vessel, places tension on the clots. All of this kind of pops the clot and you have worsening hemorrhages. So that's the theory and the thought behind that. Permissive hypotension has a lot of different names. Its research mostly is from penetrating trauma, and there is some controversy as part of it. The whole point of this is as a bridge to emergency surgical resuscitation. It's the idea to avoid over-resuscitation that can lead to rebleeding and worsening perfusion. This was kind of the original landmark study in 1994 out of Texas that really showed us that hypotensive resuscitation was something that could improve outcomes for penetrating trauma. And since then, every month there's something published about hypotensive resuscitation and fluids. But there is some controversy. There's some quality of evidence issues. There's a lot of animal trials, not necessarily a lot of human trials. There's varying BP goals, blood pressure goals, depending on the patient. Blunt versus penetrating. What about traumatic brain injuries? What do we do with those patients? There's even folks that are concerned about permissive hypotension in pediatrics. So there is some ongoing research, ongoing debate. Specifically with regards to TBI. So what we know is that a single episode of hypotension in TBI doubles mortality. That was put out in early mid-1990s. A study showed that. And so that's been kind of the mantra of avoid hypotension in TBI. So what we have done is we have kind of set through statistical analysis and whatnot, a systolic pressure of 90 is the threshold to avoid in traumatic brain injury. And so the hard place, the rock in the hard place is we want to keep their pressure low so they don't pop the clot, but at the same time we need to perfuse their brain so that they don't have worsening traumatic brain injury. And this is definitely a rock in a hard place. There will be more information to come that's already been presented at a couple of conferences out of Arizona that may change this cutoff of 90. You may see this actually be raised higher in the coming years. We'll see. And so there are a variety of different guidelines from the Eastern Association of Trauma that support this route of incremental fluid boluses, the presence of a radial pulse, improvement in mental status being the markers of your resuscitation, not necessarily a blood pressure, except for those with traumatic brain injury where the target's a systolic over 90. And the TCCC in June of 2014, so since EMS Today last year and now have updated, and those guidelines agree as well. One of the questions that comes up in trauma patients is, well, if we don't want to use fluids, if fluids are bad, should I use pressors? Can I use a little bit of push dose epi? That's kind of making its way in the emergency medicine world, and flight programs are starting to do push dose epi. Can we do that? And I just wanted to throw in one slide on this. This looked at vasopressor use in the first 24 hours of trauma, and what they found was that there is evidence that early use of vasopressors for hemodynamic support after hemorrhagic shock actually may be worse for outcomes. And so I think most trauma centers, most trauma surgeons, emergency medicine physicians would say that early use of vasopressors should not be used in place of fluid resuscitation after significant injury. So just something to think about and look at in your own system. And remember at the end of the day that only about 6 to 8% of trauma patients have immediate hypotension. It's actually pretty low. But 1/3 of those causes is something other than blood loss. So we focus on hemorrhage, but don't miss the pneumothorax. Don't miss the underlying STEMI that's causing their hypotension. Just keep that in mind. So damage control resuscitation in the last bit here. So damage control resuscitation is a bundle of interventions, strategies to do three things: minimize blood loss, maximize tissue oxygenation, and essentially maximize outcome. The goal is to keep up with the resuscitation, not catch up, and it has some big components. So permissive hypotension is what we've already talked about, so targeting the palpable radial pulse and the mental status versus a specific blood pressure. Hemostatic resuscitation, which is minimizing those IV fluids and maximizing blood products, and damage control surgery. So I would submit to you that the first two are you and I. That falls directly into our wheelhouse. That is what we should be doing, what we should be focusing on. I'm not a surgeon, you're not a surgeon, so damage control surgery is not what we will do, but it's part of this strategy. Damage control resuscitation can be thought of as the preemptive treatment of the lethal triad. That's a direct quote from this article from Journal of Critical Care Medicine. To truly achieve benefit from DCR, early initiation of these techniques is critical. You. That's who they were talking about, is you, as early as possible. So this is a take-home. I don't believe this was in your handouts. My apology. This is showing the spectrum and continuum of care. This is one of my favorite slides of everything I'm presenting at EMS today this year, is this continuum of pre-hospital through hospital management and the things that we can do in EMS with regards to damage control resuscitation, and the term being called, being moved out into the hospital of remote damage control and ground zero resuscitation. It's very important. What you do and what you don't do makes a difference, and this is being acknowledged in the most recent literature. So think back to your last critical trauma patient. How'd you do? Well, some things you did really well, some things you didn't do well, things you could improve on, things your system could improve on. That is the name of the game. That is true for all of us. So the future of pre-hospital resuscitation. Replace what has been lost. That is essentially the key. So in that three-part of damage control resuscitation, right now, we can do the permissive hypotension and stay within your protocols, but that is something that you could operationalize in your system. Minimize IV fluid resuscitation, that's something that you can do. Blood product transfusions, that's not something typically that a ground-based 911 service can do. There are a couple of places that are doing it, and I'll show you that. There are helicopter services that are doing that. So if you partake or have relationships with a helicopter service that does have blood products, you should be aware of that and understand the importance of that. But is there a role for moving that blood product resuscitation, so giving a patient what they have lost back for EMS? And there absolutely is, and we'll walk through that. So the most ideal replacement for hemorrhage control is fresh whole blood, right? You bleed it out and you get it back in. It's got everything you need. It's got all the factors, all the proteins and the right balances, etc. But the reality is that when we have done this for years and years and years and years, until kind of the mid-90s, we started to get rid of this because there was concern about disease transmission and some of the associated risks and wasting products, etc. And so it's gone by the wayside. Now we use components of blood. We don't give fresh whole blood. Typically in the civilian world, we give components of that. So you'll give 1 unit of packed red blood cells, you'll give a unit of plasma, you'll give it a platelets, whereas whole blood is all of that together. It is your blood. The military still does it. It's actually their preferred resuscitation through the TCCC. And the way they do it is fascinating, and it truly, in my opinion, is the right way to do things. But in the civilian world, we have component therapy. So we take blood, we spin it down, and we have the components, and we try and give whole blood back to the patient. That's how we're managing these folks in damage control resuscitation. There are folks, as I said, that are doing this, and there is more literature coming out. In 2015 out of Texas, looking at helicopters that have blood products versus helicopters that don't have blood products, there is a survival difference. There is currently one ongoing trial that, actually there's 2 helicopter studies. PROs have just started at our institution yesterday or 2 days ago. The PAMPER trial is ongoing as well, looking at plasma and blood product transfusions on helicopters, and does it make a difference compared to those helicopters that don't. Here's a picture of our cooler straight out of our helicopter. It's got 2 red or 2 packed red blood cell and 2 yellow or 2 units of plasma. And we take that on every single flight. Every patient, every flight, it sits right next to me in a console, and it's there when we need it. So the benefits of plasma. I've talked about this a little bit. I've talked about some of the problems. What is the plasma aspect of this? So when we were talking about coagulopathy, I said that basically coagulopathy is your ability for your body not to make clots. The component of blood that makes clots for you, so red blood cells carry oxygen, platelets help make clots, But the other aspect of clot making, those factors, the proteins that make the clot, are contained in the plasma. And so there is a huge movement that plasma really should be the fluid that we give and that we resuscitate patients with in trauma, to the point of there are systems, and I'll show you this around the world, that are getting rid of crystalloid, gone. Just, it's disappeared for the use of trauma patients, and they're using only plasma. Other benefits of plasma, not only does it have the clotting factors that you need to make clots and stop bleeding, but there's evidence that it improves that inflammation. I told you that that's one of the causes of coagulopathy, is you're badly injured and your body just becomes generally inflamed. There's evidence that plasma improves that, improves platelet function. In large animal studies, there's evidence that it's been shown to reduce the size of traumatic brain injury. And what we're beginning to see through research that is ongoing, I showed you that one study from this year that was published, is that the earlier administration of this, the faster that a badly injured patient receives plasma, the better they do. And so that makes a very strong argument for what you and I do in the pre-hospital setting, to have plasma. But there are some logistics with this, right? So I would be an amateur if I stood up here and I said, oh, we should have plasma on every ambulance, right? There are some real logistics to this, right? So blood products are frozen. How do you get them? How do you thaw them? How do you administer them? There are some real logistics to making this happen. I was involved in the project to get plasma on our helicopters, and it was a 5-month process, 25 meetings. I mean, it's a logistical process to make this happen. But there are systems in the country that are doing this. This is out of Denver. This is ongoing right now, sponsored by the DoD. It's the combat research study, and they're looking at giving 2 units of plasma versus standard IV therapy by EMS. So they're hypotensive, they're tachycardic, and they're looking at 24-hour, 28-day mortality of patients that got fluids like we normally would do, and those that got plasma. They're using frozen plasma, so they're actually outfitting their ambulances to thaw it, and they're thawing it in 2.5 minutes. The system to set up in the ambulance, they talked about 13 grand to set that up, so it's an expensive adventure. But they're doing this research, they're getting over some of those logistical hurdles, and we await for those results. Another one that is ongoing right now, so pre-hospital use of plasma for traumatic hemorrhage. And this one's out of Virginia College, and I think, in my opinion, I think this is probably, at least in the systems that I'm intimately familiar with, I think this is the setup that probably would work in my system. Maybe it would work in your system. Sponsored by the US Army. They're randomizing injured patients to receive 2 units of already thawed plasma. So now that has a shelf life. That's got to be recycled every 5 days or so. So there's some logistical stuff of, you know, it's thawed at the hospital, goes into their supervisor quick response vehicle for a couple of days, and then goes back to the hospital. So there is some logistics there, but they're taking hypotensive tachycardic patients. They've got these supervisor vehicles with the refrigerator in them already, and they're giving plasma instead of normal saline for their critically ill trauma patients, and they're looking at 30-day mortality. That's exciting stuff. Now, I think at the end of the day, and I think maybe there might be some military folks in here that have experience with this. If you do, please come up and talk to me afterwards. I'm enamored by the idea of dried plasma. So dried plasma is this idea that we can take that component of blood that has all of those benefits that I've already talked about, decreasing endothelial cell wall inflammation and providing the clotting factors. We can treat it and store it in such a way that it's actually a powder to be reconstituted and then just hung. No refrigerator, no thawing, just mix it up, 3 to 5 minutes of reconstitution, and you hang it. This was previously done. This was done by the US military in World War II. And then with the advent of helicopters, they thought, you know what, with helicopters, we probably don't need to continue doing this and research on this because the helicopter was taking patients directly to the field hospital. So we kind of stopped looking at this in the US. The French and the Germans, however, continued doing research. They continued to improve the process over the last 10 years. And they've come up, and they're essentially the only 2 companies in the world that are doing this, making dried plasma, a powdered plasma that you reconstitute and hang it, and it gets you the benefits of the blood product that was already, the same as it was already frozen. It is FDA approved for US Special Forces under kind of limited contingency circumstances, and that's part of TCCC. It is there. And so that's why I said if any folks in the room have experience with this, please talk to me afterwards. Dried plasma can be stored at ambient temperatures, has a long shelf life, 15 to 24 months. And if you're an EMS operations guy like I am, anything that you can keep on the shelf for 24 months is a good thing, right? Okay, so that's a good thing. You reconstitute it with 200 mLs of water, and it takes about 5 to 10 minutes. And these are some averages because there's 2 different products, so there's some subtleties to each product. And the lab demonstrates that it maintains the global capacity to make clots as if it was normal blood. And the best data that we have shows that even after 24 months being reconstituted, that this dry plasma really does retain its ability to make clot. It's got a strong safety profile. Germans and the French have huge databases of this information, and we've got a very strong safety profile. But the limiting factor in the US for you and I is the limited civilian EMS use. It's not FDA approved for us to use, but I think that this is coming. I think in our lifetime we will actually see this. The Israeli Defense Force in 2013, kind of over a couple of months in 2013, they essentially got rid of all saline in their ALS providers, all of them. They just got rid of it and they replaced it with dry plasma. And they have an algorithm there where they have no radial pulse, their systolic pressure is less than 80, they give 1 unit of this freeze-dried plasma, they reassess, they give another one, and they have a kind of very protocolized approach to giving dried plasma, and they're doing it across all of their ALS providers in the Israeli Defense Force. So EMS is a practice of medicine. We're in the business of delivering health care to a very unique population in a very unique environment in a very unique way. And so I hope some of this last section of the talk here kind of showed you some of the devices and some of the principles and some of the opportunities and research that are ongoing that certainly will be presented in publication and in conferences like this, but just to keep an ear out to some of these things. So here's the take-home points in the last couple of minutes, and we'll have a few minutes early for lunch. This is the enemy. I said at the very beginning, to do this right, the art of the pre-hospital trauma resuscitation is not how fast you're mobily deployed. It's not necessarily what the scene time is, although that's important to get folks to the operating room. I understand that. The real art of the trauma resuscitation is understanding that every intervention you do with these critical patients needs to be argued, it needs to be aimed at one point of that triad, if possible. Multiple if you can. The tenets of the triad, again, it starts with bleeding and it ends with death. You cannot predict when it will occur or how severe it will be. And once started, it will spiral out of control. That is a given. That is truth. But I will add these tenets now that we've done this for an hour and 25 minutes and you've sat here and listened, and thank you for your attention. I really do appreciate it. We'll add more tenets to the triad. The tenets of the triad are now this. There is much that you can do to directly make an impact. So things that we were doing or things that we were thinking about doing, there is much that you can operationalize in your system with the care that you provide tomorrow at 3 in the morning on the truck to make a difference. It takes preparation and practice. There is no doubt about it. Doing this system-wide, particularly in a big system with a lot of providers, takes a lot of education, takes a lot of time. But do not forget what you cannot see. Remember that plug for the pelvic binders. And then great advances have been made and even more to come. And hopefully you got a perspective of kind of an interest of what's to come in the coming years. So at that point, I'd be happy to take any questions, and it's almost lunchtime. Thank you, everybody.